So the class 2 elastics has the horizontal component and the vertical component. And the vertical component, what is that it causes the extrusion of the molars, and it will penetrate, and the extrusion of the mandibular molars, which will penetrate into the fluid space, reorienting the occlusal plane. And the horizontal component, what it will do in the dentition is that it will cause the mandibular molars to rotate or tip majorly, and it will cause the mandibular anterior teeth to procline, and also it will display the clastoelastics will displace the whole mandibular dentition anteriorly. So clastoelastics can, while looking about the effects of the clastoelastics, we can say that the clastoelastics can be used for the in case of scleroclastic patients before the orthodontic surgery, so that we can decompensate the dentition. And also, while decompensation in case of scleroclastic patient through the use of clastoelastics, it is sometimes very difficult to get the decompensation. So in such cases, the Jensen et al. And Allen et al. They have suggested through the use of the skeletal anchorage system. So the temporal skeletal anchorage system, this can provide the proper sagittal decompensation in the conventional, or also in the surgery first approach. And this is given by Kawamura et al. What they have done is they have used the mini plates in the maxillary anterior direction and in anterior portion and the mandibular posterior direction, and they have used the clastoelastics in order to decompensate the dentition. So the temporary anchorage device, this can be supported both by the intra and inter-arch, and also the class 1 and class 2 elastics. And the amount of intrusion that was produced in this study, this was greatest at the central incisor edge, and this was gradually increased when the force angulation was increased from -30 to +30 degree. Whereas in case of the distal buccal course of the second molar, there was extrusion. There was extrusion of the second molar, and also the occlusal plane at -30 degree. There is anti-clockwise rotation, but when the angulation is increased to +30 degree, there is the clockwise rotation of the mandibular occlusal plane. So the limitation of this study is that since it is a finite element study, it may not replicate in the tooth movement may not be replicated in the clinical situation. So concluding the journal club is that the occlusal plane, this occlusal plane rotation can be this dependent upon the force application, and the force application will depend upon from the center of resistance of the whole dentition. And the elastic deformation of the archway, as well as the clearance gap between the bracket and the archway slot, this will cause the buccal window tipping of the second molar while during the midsection of the whole dentition. That is, if the center of the force application will pass to the center of resistance, then and if it passes when the angulation is -30 degree, then there will be more buccal tipping. Whereas when the clearance gap is decreased between the archway and the bracket slot, then the buccal tipping can be decreased. And since we know that even though the force angulation is to the center of resistance, then there will be buccal tipping. So what we can do in such cases is that we can use the lingually prevent as well, so that we can prevent the buccal tipping of the second molar when we are doing the midsection of the whole mandibular dentition. So for the critical appraisal, the inclusion and exclusion criteria is not applicable in this study, and ethical clearance and also the patient consent is not required for this study. Also, the hypothesis of the research was not mentioned. Also, the sampling process is not required. And in this study, the measurement error has not been mentioned. And for the description and tabulation result, this matched with each other. And also the statistical analysis was not required in this study. And the result has been clearly documented and compared with the previous study. So these are the references. Thank you.